Good morning. Wow. This is a good group because I never have this success on my monthly leadership meetings here, so thank you. I want to welcome everybody to the 18th Victor A. McKusick lecture today, and what a great annual event that we have here. And I would definitely like to welcome those that are not only in the audience, but also those that are online. So thank you for participating today. It's going to be, I think, a great day and a great lecture. We're excited about this, and then also just congratulations to those of you, the 42 that are here today from Tufts University Medicine and obviously here at MaineHealth. Excited to have the students of the Maine Track program here. So let's give them a hand. My name is Britt Cruz. I am the president of MaineHealth Southern Region, and I get to kick off this event every year, which is exciting for me. And I thought, some of the people here have heard me already talk twice about this, and so I thought, okay, the third time I'm going to come with some new material. All right, so I thought to myself, okay, when I saw 2030, and anyone that knows me knows I'm a numbers person, I thought, I'm going to be heading from one lifetime of being in my 50s to no longer being in my 60s, or in the 50s and going into my 60s during your 4 years in school. And I thought about what does that mean to me as a person from a health perspective. And so anyone that knows me knows that I'm not very good with AI, but I thought this might be a great opportunity for me to utilize AI. And the first thing that I pull up was the one that I thought, oh, wow, this nailed it. So this is what I have to look forward to, and this is why the 41 of you are so critical to healthcare and me coming into the future. In your 60s, the primary health risks shift toward managing chronic diseases and preventing age-related physical and cognitive decline. The most common threats include heart disease, cancer, stroke, type 2 diabetes, Alzheimer's disease, and bone joint deterioration such as osteoarthritis and osteoporosis. Additionally, because that wasn't enough, the risk for severe respiratory infections like flu, pneumonia, and RSV and shingles increases due to a naturally waning immune system. I didn't really like that word, waning. So it talks about managing the risk, and then the big three come up. Routine screenings. Keep up to date with preventive checkups, including colonoscopies, usually until age 75, mammograms, and prostate exams. Regular blood pressure, cholesterol, and blood sugar checks are critical for intercepting cardiovascular disease and diabetes. Okay, there was a big number of people that just turned 60 in this world, known as the baby boomers, and they have all come through. Well, then there are those that are the front end of Gen X following them. So to think that, I hope you never think that you're not going to have a ton of work in your future. Okay. So as part of this, I would like to recognize the class of 2030. Exciting time for you. I hope that you have a wonderful time. I know it's going to be a difficult time, challenging time, but you have that light at that end of that tunnel that says, you're going to be a physician and you're going to do great things for our patients. That's what excites me as a person that's going to be receiving that care on a regular basis going forward. I'd like to recognize our faculty. Are there any faculty members in here? A lot of you in here. Thank you for the work that you do. We could not do this without you. And obviously, it is so critical to the teaching and just the incredible experience that our students get is because of the great work that our faculty does. And so thank you for that. I'd like to, just for a moment, think about the past of the Maine Track program, which hundreds and hundreds and hundreds of people have come through the Maine Track program. We've had just incredible success with the program. We have Dr. Normandin, Dr. Adam Normandin, who's going to be speaking today for us, part of the Maine Track program. And so, and just what it has done for the state of Maine has really been amazing. So I just want to just continue with this great program. And as part of that, one of the things that has truly helped us is the benefactors. And those people who have really provided means for us to continue this program. The scholarships that we provide our students are really great. It really does help from a debt standpoint going forward. And then, and just the continuing, the continuance of that, and that's been going on for the length of the program that we've had. But think about the future. Obviously, the cost of medical school continues to go up, but we continue to try to match that in terms of the scholarships that we provide. So I want to thank all of our donors, all of those people that have come, gone, and for the future that have provided means for this program. Thank you very much for that, and just want to point that out. So with that, I'd like to introduce the Dean and Professor of Medicine, Tufts University School of Medicine, and Chief Academic Officer of Tufts Medicine, Dr. Helen Boucher.
Thanks so much, Britt, and welcome everybody to the 18th Annual McKusick Lecture. I have to start with a confession. I'm about to be 62, so I'm already there in needing your services. And happy to say, no meds yet, pretty healthy, go to the gym, and we'll keep working on it. As Britt said, I'm the dean. I have the privilege of serving as the dean of the medical school, and I'm entering my 6th year, which is hard to believe. We have a number of leaders from the School of Medicine with us today, and from Boston. I'm going to ask them to stand so I don't miss anybody. I see Dean Bacher-Lind. Where's Dean Brown? Dean Ehrlich. Dr. Jason Hall, our chair of surgery, is here. Welcome. Jen Greer-Morrissey from Tisch. Thank you for being with us. And Mary Pat Lose, our executive administrative dean, is here. And thanks to everybody who's with us online. There is a village working hard for your education from Boston, and we are so delighted to celebrate with you today. For 18 years, as Britt mentioned, this collaboration between MaineHealth and Tufts University School of Medicine has built a really strong bridge between academic excellence and healthcare with a regional focus. The Maine Track partnership was envisioned by several in this room to address a pressing challenge, one that is still with us, right? A growing shortage of physicians in Maine, especially in rural and underserved regions. And thanks to the dedication and vision of so many leaders who are with us today and some who are not, this program has become one that can transform not just individuals, but entire communities. So you in the class of 2030, for you today marks the start of your medical journey, and we know you're going to accomplish great things during your 4 years of study here. We believe deeply in you and your talents, and we believe strongly in the choice that you've made to study here in this beautiful state with a focus on improving access to high-quality care for all the residents of Maine. You know, the Maine Track has not just addressed a need, it has sparked innovation, pride, and partnership. It's brought student educators, physicians, and communities together in a shared vision of healthcare that is Maine-focused and patient-centered. And we just spent the last 2 hours talking about the future of the program, and I couldn't be more excited. It's important for you to know that this continues to be guided by the spirit of the founders of the Maine Track, leaders like Dr. Peter Bates, who's not with us today, but with us in spirit, who said, "My goal is simply to try to make a difference in the health of Maine citizens and the health care they receive." Couldn't be more true today. And we've seen with each graduating class that measurable progress towards our goal of improving high-quality access, led by compassionate, highly trained physicians who understand Maine because you've lived, trained, and grown here. And a huge number of you are from here, which is wonderful. So as we heard, you're going to soon hear from Dr. Normandin, who's a Tufts University School of Medicine graduate and whose career is a testament to the Maine Track. Before that, I just want to say a word to you about the education you're about to begin. I had the privilege of going on service in the hospital a couple of weeks ago and spent a week with a great team, including a fourth-year medical student, Abe, and fellows and residents. It is such an exciting field that you're joining. But the world is changing, and you know this from even when you went to college and your clinical experiences, it's more transactional. We're addicted to our devices. We have so much information at our fingertips. And my one piece of unsolicited advice for you is to take time to make relationships. Relationships with each other, with the people you work with in the clinic, the nurses, the doctors, the physical therapists, the social workers. We know that healthcare is better when the team has good relationships. I also believe and know in my heart that the benefits that you receive, that we all receive as physicians, are more meaningful when you have those relationships with each other and with your patients. It never gets old. It never gets old being part of the most intimate details of someone's life, being trusted with that. So my hope for you is that you'll take the time. Take the time now to get to know each other. Take the time as you go forward to get to know your patients and colleagues. So with that, I'll say thank you again. Congratulations again, class of 2030. And I'm happy to turn the program over to Dr. Doug Sawyer. Thanks.
Good morning. I'm Doug Sawyer. I'm our academic dean for the Maine track and chief academic officer for MaineHealth. I jokingly refer to myself as Dean of the North for y'all. It's really wonderful to welcome y'all here for this class of 2030. We are honoring this entry to this Maine track with the name of Victor McKusick. And sometimes the McKusick family is able to join us, but I don't see them here today. They might be online. Raise your hand if you, I'm looking at our class of 2030. Raise your hand if you know who Victor McKusick was. Okay, so this is good. All right, something to learn. So Victor McKusick grew up in Parkham, Maine, with his twin brother Vincent, and he became interested in medicine and went down to Baltimore, studied at Johns Hopkins, and then became faculty there, and spent his whole career there. He started out as before they were cardiologists, he started out as a cardiologist. He actually had a really loving relationship with his stethoscope and did a lot of work around acoustic analysis of people's heart disease, including things that a lot of clinicians miss today with their stethoscopes, like constrictive pericarditis, for example. But then he got really fascinated by genetics. He got interested in inherited vascular disease in particular, and then became so passionate about it that as we began to understand the genetic basis of disease, he really became the father of genetic medicine and contributed widely to that field. It was a series of textbooks at first, but then it became a website that I require all of you to look at during your med school, called Online Mendelian Inheritance in Man, or OMIM. Has anybody looked at OMIM before? Oh, okay, this is awesome, because you're now ready for your first homework assignment I'm about to give you before I turn it over to our speaker. So this was after your time, Adam, that we started this tradition that you get your first homework assignment at the McKusick lecture. And it's in honor of Victor McKusick that we ask you to identify what is your favorite gene. You have 4 years to do that. It's not yet a requirement for graduation. I keep trying to work it in, but our deans don't let me do that. But it is a request for graduation that you somehow become familiar enough with the human genome and the genetic basis for disease that you find yourself a favorite gene. And it doesn't have to be a disease-associated gene. There's a wonderful example of one of our students who had actually, I'm going to blank on what the gene was, but it wasn't disease-associated gene to my knowledge. In any case, that's your job, and you don't have to have one favorite. You can have multiple favorites. I have 4. And your favorite today doesn't have to be your favorite tomorrow. You could change your favorite, just like maybe the way you treat some of your brothers and sisters or friends. So in any case, that's your homework assignment. I'm going to stick to it, and I'll look for you guys to chime in with that before you graduate. It is really an honor and a privilege to introduce Adam Normandin, and I'm actually not going to say a lot about Adam because I know that he's going to tell us a story that's better than any introduction I could give. But suffice it to say that I am so thrilled that our admissions committee saw something in Adam, and Adam saw something in the program that connected us in 2011. And actually, by the way, Victor McKusick died in 2008, and the McKusick lecture began in 2009, which is interesting to know, and factoid. But back to Adam. And Adam, a graduate of our program, stayed with us and has built a practice that is really impactful and really helping a part of our community that I'll let him tell you about. So Adam, thank you for being here.
How about now? Better? Yeah, there we go. I can hear that. Wonderful. Well, good morning, everyone. Thank you for being here. As Doug said, I'm Adam Normandin. I am a faculty member at the med school and part of our family medicine residency. I'm also the education and outreach lead for the Preble Street Learning Collaborative, which is what you're going to hear a little bit more about today. And most importantly for today's event, I am a Maine track graduate of the class of 2015. A couple quick disclosures before we get going here. The Preble Street Learning Collaborative has received funds from the American Rescue Plan Act, or ARPA, grant funding from SAMHSA, HRSA, and I sit on the HIV Street Medicine Advisory Council, which is also a HRSA-funded project. I also want to make an incredibly important disclaimer before we get going, much to Dean Boucher's point, is that while I'm standing up here alone today, these stories and this work that you're going to hear are not just my stories. And while I may say I at times, it's really a we. I have the privilege of working alongside an incredible and extraordinary team of case managers and health guides and PAs, psychiatric NPs, data analysts, and grant managers, and many, many more. And the truth is that this is an interprofessional team at its finest, and every role is essential, and none of this work could happen with just one person. The minute that Dr. Sawyer asked me to come and speak with you guys today, I had some immediate reflections and was thinking back to many years ago, July 2011, when I sat in these very seats at my own McKusick lecture, and I thought it might be fun to share with you a few of the thoughts that I had, and maybe these will resonate with you guys. One, someone has made a huge mistake. I don't know what was going on in the admissions committee that day. I don't know. I'm in medical school. Someone was asleep, didn't get enough coffee. I don't know what happened. And everyone in this room is so smart. Like, there are doctors, all these other medical students. They are clearly more well qualified than I am. How did this happen? But at the end of the day, I was incredibly grateful to be here. And I had wanted to be a doctor and to serve my community for a long time. So to be in these walls and starting that journey was immensely meaningful to me. I also thought it might be fun to talk about some reflections that I had coming into today. Believe it or not, 15 years later, which is a little painful to admit. But the first thing that came to mind was that someone has made a huge mistake. Doug had asked me to address the incoming students, about 40 of them, and I'm looking around, and it may be that I'm in the wrong room. So Doug, if we want to move on, we can do that at any time. The second thing was that everyone here is so smart. And the thing is that over the past 15 years, I'm actually even more convinced at how true this is as I've watched the learning, the research, the teaching, the patient care of this extraordinary institution. And you may see where I'm going with this, but the final reflection was that I'm immensely grateful to be here. To be sharing the work that we do is sincerely beyond a dream come true. So thank you to Dr. Sawyer, the deans, the Maine track, and to the McKusick family for having me. Now, the other thing that I think about back in 2011 was this old 1995 Nissan Altima that I used to drive. She wasn't much, but got me where I needed to go. We'll come back to this. I feel like I've had a chance to get to know some of you a little bit here. I got to read through your bios, and I put together this list, not all-inclusive by any means, but of the different organizations that some of you have been involved with in your time leading up to medical school. And to me, I see already a demonstration of commitment to Maine and communities that are underserved throughout New England. I see things like Maine Adaptive and Thrive and Greater Portland Health and Planned Parenthood. Nowadays, the admissions committee is crushing it. No more sleeping through it like they did 15 years ago. And the other thing that I tried to, put together, what's the thread here? What are the things that bring this all together? And for me, the immediate thing that I thought of was love. And at the risk of sounding too soft for you all, I want to put an academic spin today on this idea of love. And if you look it up in Webster's dictionary, you might find things about commitment and things of that nature. And I will draw your attention down to the quote of using it in a sentence that love is not merely something you feel, but something you do. And so I was going to bring you through a long-winded chart of different Greek philosophers and how they visioned love. I thought we could maybe do that in a more entertaining way. So there's one type of love that Taylor and her guitar sing about, and Taylor talks about romance and desire. That's one type of love, but there's also the love of coworkers. This is my residency class, and coworkers depend on one another for jobs to get done. By the way, 1, 2, 3, 4, 5 Tufts graduates and 1 non-Maine tracker, but we won't hold that against her for today. There's also the love of family. This is my beautiful family and my wife, Corinne, who's a pharmacist at MaineHealth, and our 2 daughters, Ada and Grace, and this other guy that they keep around for pictures. I should also mention that not all of these types of love are mutually exclusive, and I'll show you a more recent picture of my residency class that has now multiplied into some 30 people, so maybe there's an aspect of family there as well. However, importantly, there's another type of love that kind of supersedes or sets itself apart from the rest of these, and that's the idea of agape. And it's a selfless and unconditional love. I was first exposed to this idea on a service trip to Tijuana, where I have this very vivid memory of standing here in the border wall, and things were much different back then. This is 2005, but you can see that these caskets on the wall have numbers of the number of people that have died trying to cross from Mexico into the United States at each given year. But when you stood here, and you can't quite tell in the photo, but just on the other side of this fence is San Diego, lush, beautiful, green city, and on the side that I'm standing on is a barren desert of Mexico, and we had just spent the day in the basura, right? The community in the landfill where everything, all the houses were made of whatever they could find there in the dump, and we had been building a classroom for the children to go to school. But it wasn't necessarily just the poverty that stuck out to me. It was really the juxtaposition and the contrast of the have and have not right on top of each other, separated by a small wall, but really so much more than a wall, right, of history and economics. And the other thing about this trip that was really meaningful to me was that the full name of it was called the Pedro Arrupe Service Immersion Trip. And Pedro Arrupe was an interesting guy. He actually started off in medical school wanting to be a doctor, but about halfway through, he ended up making a change of plans and actually went to the seminary to become a Jesuit priest. And what Arrupe is famous for is preaching the idea that a fulfilled life is one spent walking alongside and caring for the poor, the marginalized, and the excluded. And this quote of his always stuck with me: fall in love, stay in love, and it will decide everything. It's important to note, of course, that that he is talking about this selfless and unconditional love. So we're going to transition now to speak a little bit more about homelessness. And to start that discussion, I want to do a little reflection. So I want people to take a look at this photo and close your eyes. And I want you to imagine for a moment that you're driving down this off-ramp here. And as you're approaching the end of the off-ramp, you see a man standing there, jeans on, shirt off, very, very skinny, tanned from being in the sun so many days, and holding a sign that says, "Anything will help." And I want you to think about what you do next. What comes next after that? Do you scrounge through the seats to find some spare change? Do you look in the back seat for maybe a pair of socks that you give, or a granola bar that you might find? You can open your eyes. And I'm not here to say that there is a right answer about what to do or what not to do in this situation, but what I do want to say is that I think we probably all, as we think about this, can resonate with some type of sort of moral uncertainty in the situation about what's right and wrong and what's best. And I just want us to sit with that idea here while we talk a little bit more about homelessness. homelessness has a pretty interesting history. Many, many years ago, pre-1300s, homelessness had no negative context, and people were called vagabonds or wanderers, and it was really a matter of circumstance that people were homeless, and it was because they followed crops around, and so having a permanent home just didn't make sense. And it wasn't until the mid-1300s, when the plague wiped out so much of Europe's population, that there were labor shortages that ensued. And England started making some rules and laws restricting movement to try to stabilize its economy. So probably, one of the first, and at least in terms of homelessness, first structural and political determinants of health all these years ago. And that continued to escalate up to 1572 in the Vagabond Act, where people were actually branded with a V if they were found idling for 3 days. In subsequent encounters, they could be enslaved for 2 years, life, and then executed as a felon. Now, fast forward to recent years, and this still is going on in some ways. In 2024, we saw the Supreme Court make a ruling on Grants Pass, which is what allowed encampment sweeps throughout this country for people that were camping outside, and also allowed cities to cite and fine and arrest people for doing so. And now we're also preparing for the outcome of H.R. 1, aka the Big Beautiful Bill. And what we do know about that is that there are new eligibility rules for unemployment that are more stringent and require a more frequent verification process. And with not to be at all political here, but what we do expect is that this population that's already quite disconnected from care is going to have a very hard time keeping up with this documentation. And so we anticipate that things like a decreased enrollment in safety net programs like Medicaid and SNAP are going to go down significantly. I also want to point out these two photos here as some more sort of subtle examples here. So you may look at this park bench and you may say, oh, that's so nice that they put some bars in there for grandma so she can push herself up and get out of that. But unfortunately, what this is that these are bars to make it so that no one can sleep on this bench. You can also look at this exhibit down here in a railway in DC, an underpass, and what looks like these nice icicles hanging from the ceiling are actually hundreds of thousands of lights that are meant to illuminate this space so that it was uninhabitable and that no one would sleep under this bridge. These are examples of hostile architecture, and if you look at with the naive eye, you may not know, but if you start to keep your eye out for these, you'll see more and more examples of this kind of thing. Not to spend a ton of time on this, I think a lot of people understand that homelessness is on the rise year over year in the United States. This is data from HUD showing that, with the dark blue bars being sheltered homelessness and the lighter blue being unsheltered homelessness. Both are increasing. We see similar trends in the state of Maine. Now, some of you may be thinking, we're in a hospital. We talk about diseases here. Why are we talking about homelessness? That's a social problem. And so I bring this definition to you from the WHO that says a disease means an illness or medical condition, irrespective of origin or source, that presents or could present significant harm to humans. And so I'll give you a little bit of data. This is a study out of Minnesota where over the course of 19 years, every 3 years, they were surveying people experiencing homelessness about their health conditions. And what they were categorizing were people's reports of different medical problems, and they put that into physical health, like hypertension, heart disease, mental health, mood disorders, schizophrenia, bipolar, trauma, and substance use. And really the numbers that came back from these surveys were quite profound, that up to 77% of people had at least one of these chronic conditions, 30% had 2, and 16 had 3 or more, or had something in all 3 categories. I would also note that this study didn't take into account whether people were chronically homeless or more short-term, and also whether or not people were sheltered or unsheltered. And I'll tell you that the population that we work with is chronically homeless and unsheltered for the most part. So anecdotally, I would guess that the numbers in our population are much higher than this, but I think these are quite high to begin with. Some healthcare outcomes, and to give Britt a couple numbers here. first and foremost is that all-cause mortality against matched cohorts show that people that live unsheltered in Massachusetts versus a matched populations had a 10 times higher all-cause mortality, and compared to a sheltered population, a 3 times higher all-cause mortality. This conveys about a 20-year shorter life expectancy. Additionally, expenditures for taking care of this population tend to be much higher. In fact, the measure was 3 times higher than the average matched Medicaid recipient. Both of those studies come out of Massachusetts. And another one was that 3.73 more likely to be a high utilizer in a hospital system in Atlanta. So we come back to this slide, and I hope that just looking at a little bit of data, we can agree that homelessness not only is one disease, but oftentimes 2 or 3, and could present and does present much more hospital utilization, shorter life expectancy, and really a lot of harm to people. So we're going to transition a little bit here about what are we doing about that at MaineHealth. And in 2017, we opened the MaineHealth Preble Street Learning Collaborative to provide low barrier care to this population, but also with the dual mission of educating tomorrow's caregivers about these types of issues facing marginalized populations. The care that we provide is different and really hard to put on a slide, so I'm going to share a few patient stories with you. The first one is about Todd and Todd's left foot. Todd's foot was red and swollen and quite tender, very concerning for an infection. And Todd, we started him on oral antibiotics, and his foot wasn't getting better. We tried a few different types of antibiotics, and nothing was working. And I said to Todd, I think it's time that we send you to the hospital, get some imaging. You may need some IV antibiotics. And Todd came back and said, absolutely not. Now, our patients going to the hospital is a complex thing that we don't have time to fully dive into today, but in this circumstance, it was the first couple months of COVID, and no one wanted to go to the hospital unless absolutely necessary. So eventually, we convinced Todd to get an x-ray of his foot, and out back, it's probably hard to see, but Todd had a bunch of free air up on the dorsum of his foot, which can be concerning for a really serious infection. One of which is called necrotizing fasciitis, and the radiologist called me urgently and said, you got to find this guy immediately. He is going to lose his foot and probably die if not. And so I went and found Todd and explained this to him and had a discussion. He said, thanks, doc, that is great. I really appreciate it. There's no chance I'm going to the hospital, but what else can you do for me here? I lost a lot of sleep in the subsequent days about Todd, and you know, Todd very clearly had capacity to make that decision, and so we certainly want to give him the autonomy to do so. And eventually, after talking with infectious disease colleagues and pharmacy, we decided to give Todd injections of antibiotics, intramuscular injections. And so at the time, he was living in the USM gym, which had been repurposed as a shelter in early COVID. And so we would go back in the back corner of this gym here, and my MA would come with me and stand in front and give us a little privacy. And by the end of 2 weeks, I didn't even have to tell him to drop him. He just knew that we did his gluteal injection, and we went on. And sure enough, after a few weeks, Todd's foot got better, and I still see him biking around town, and his foot is totally fine. Now, I'm not here to say that this was the gold standard of treatment at all, and I firmly believe that we need to always be offering that to our patients. However, at the same time, I definitely need to have a contingency plan and to figure out how I'm going to meet someone with with a plan that works for them. And so if I'm trying to care for someone unconditionally and selflessly, the main point of the story is that you've got to go to the people. The next story is about Jerry. Jerry's a guy that came to the Learning Collaborative that we'd never really seen around town before, and it turned out he had been pretty new to homelessness. But he had a wheelchair, and so we made some deductions that maybe Jerry had some healthcare issues. And for probably 3 weeks or so, Jerry came in, and he didn't really want to interact with doctors or the medical staff, but he would come in and he'd rest. We'd bring him some snacks. He'd shower. And this went on, like I said, for about 3 weeks. And then one day, he said to the medical student who had been really involved in snacks and showers, et cetera. He said, "Hey, listen, my feet are swollen. Can you take a look at them?" And like a good fourth-year medical student, she asked some very appropriate questions and did a focused physical exam. And she came running and said, Adam, something is terribly wrong with Jerry." And so we went to check out Jerry, and sure enough, Jerry had a massive distended abdomen, which the doctor and me said, "Hey, we got to get stat labs and imaging for this guy. We got to figure out exactly what's going on. He probably needs that fluid drained, et cetera." Got to remember, though, that this was a guy that it took 3 weeks and many, many granola bars to just mention to someone that his feet were swollen. So going to the hospital, again, was not something he was interested in. But over time, as we built this relationship and continued to encourage him to do that, he did eventually let us order some labs for him outpatient and obtain some imaging. And we diagnosed what we expected was that he had liver failure due to untreated hepatitis C. And with the help of our social work team, we were able to get him over to the Gilman Clinic and do outpatient paracentesis procedure to draw, I think, about 5 or 6 liters that first time out of his abdomen. Treat his hep C, and then get him a whole slew of testing that's needed for people with cirrhosis to make sure they don't have other sequelae of disease. So again, here, if I'm trying to care for someone in an unconditional and selfless manner, I really need to have patience and be persistent, and I need to believe in client-led care. And I will say, as a brief note before moving on, that Hannah was one of 73 medical students, 73 learners that came to the Learning Collaborative last year. We had 11 Tufts students, we had 55 residents from 5 different programs, and 7 fellows from 3 different fellowships. So we have a lot of different learners that come and spend time with us. The next story is about Scott and Scott's right hip. Scott had a fracture in his right hip that was associated with osteomyelitis that was presumably secondary to IV drug use. The orthopedic team put some pins in his hip, fixed him up, and sent him on his way. Unfortunately, he continued to have infectious problems with this hip, and then several months later needed a full hip replacement with prosthesis in that leg. He had many, many more procedures, washouts, and surgeries to try to fix this ongoing infection. So even so much that they took this cemented prosthesis out of his hip and put it back in with antibiotic impregnated cement. Still didn't do the trick. And so eventually he had what's called the girdle stone procedure, which is basically a last-ditch effort where they completely cut off the head of the femur, and the ball and socket joint of the hip is no more. We worked really closely with Scott during this period of time, and wasn't, in some ways, you might think there wasn't a ton that we could do for him, but we did a lot of harm reduction for him during this time. We brought him to the needle exchange to make sure that he had clean supplies. We got him harm reduction kits so that he could care for his wounds. We treated his pain, albeit a complicated situation, with Tylenol and ibuprofen and some gabapentin for associated nerve pain from all these surgeries. And a couple of things that really stick out about him is one, that he was highly connected to our Connect, we call Van Outreach program, who did a lot of this coordination and eventually helped him get to the methadone clinic every day, which made it really turned a corner in a lot of his treatment. And by the way, our van is going to be parked outside during the reception, so I invite everybody to come and scope it out later this morning. He also, I remember my time with Scott as just being a brilliant guy who taught me so much, and listening to him about different things about what it's like to live with addiction and why people inject and where and how. And so I learned a lot from Scott, and we had a lot of great conversations. The great news is eventually, by working with our rapid rehousing case manager, Scott was able to get housed. And this, unfortunately, was not his house, but behind this house was this small shed. And we got to go and see Scott after he was here, and I have to tell you, he was just beaming. Scott was a really young guy, mid-20s, and the fact that he was able to show us around this first ever residence of his just meant so much for him. He was, again, stable on methadone at this point and not using any of their opiates, or he had some stimulant use. And so we were able to start treating his ADHD, and he was doing incredibly well, was actually biking himself to the methadone clinic despite that hip. And the moment that will stick out for me forever is that in the middle of all this, he walks over to the stove. Yes, this place did have a small stove in the corner, and started making us scrambled eggs. And I just can't get over how many doctors get to have that experience. So the important thing about this story is that if you're trying to provide selfless care for someone like Scott, it really takes a long time to build consistent and trusting relationships with patients. The next story is about Marcel, and I have to admit that Marcel, you're probably not supposed to admit this as a doctor, but is probably one of my favorite patients I've ever interacted with. I met Marcel, I was still a resident, and this is an AI recreation of Marcel. Hopefully that's very clear. However, it is quite accurate, I must say, except for the Portland headlight in the background. Students, don't go looking for this view, it doesn't actually exist. But the rest of it is really very accurate. His purple chapeau with the feather and his tight purple yoga pants, doing yoga, and you probably can't see that, but the clock says 4:42 in the morning. And as a resident, I was getting there at that time, and he had been there for a while, so he was always the first patient I'd go see. And without fail, every morning I'd walk in and he would greet me excitedly, "Oh, Dr. Normandin, bonjour, comment ça va?" And I would say, "Bonjour, Marcel, un peu de français." And then we would carry on in English. And Marcel had been admitted to the hospital at this time for COPD, so we would talk about his breathing. Unfortunately, Marcel's chart looks something like this, and to the med students, you haven't seen this yet, but the physicians in the room can appreciate that basically the past 2 years, he had something like 6 admissions and 20 plus ED visits. The most unfortunate thing about this story is that the whole time through all of these, we had CAT scans that showed that he had bilateral pulmonary lung nodules that were very concerning for metastatic lung disease. He had been a heavy smoker his whole life. Unfortunately, every time the discharge plan for all of these admissions was arrange outpatient PET scan as the next step in the workup for his malignancy. And then he would get discharged to his tent in the middle of the woods, which was intentionally isolated from other people. He liked to live alone. He had no family, no phone, and certainly never got a PET scan. So being the young, chipper, maybe naive resident that I was at the time, I wrote about all of these and I outlined them, and I sent an email to Joel Bottler, who at the time, I don't know exactly what his title was, we'll call him the boss. He was CMO or president. And to Joel's credit, we got a PET scan 2 days later, which confirmed the bad news that indeed this was metastatic cancer that was everywhere in his body, and he had a prognosis of probably 3 to 6 months. The good news is that we were able to use that to advocate to get him into a Housing First site where he had his own permanent dwelling at discharge here. And I got to go see him every week or so afterwards there. And the best part of our visits was that we would have pull-up competitions. And these competitions, these photos, in fact, were taken probably about a week before Marcel passed away. He decompensated quite quickly a few days later, not because of the pull-ups. And fortunately, though, because of our relationship, we were able to very quickly get him over to Gosnell, the hospice house, where he died peacefully and with dignity. And I think here, the message is about continuity of care and being able to care for someone in the hospital and in a tent and in a Housing First site and at a hospice center is really something you would do for someone if you were trying to care for them unconditionally and selflessly. And now the final story is about Jack. Jack was a 40-year-old guy. He'd suffered a gunshot wound to his lower spine, which left him paralyzed from the waist down and with neurogenic bladder, and was also unsheltered. So what that left him with as on the streets was that he had to do straight caths to help himself urinate, which you can imagine on the street led to a lot of urinary tract infections. And then also being on the street and in a wheelchair meant that he spent days to weeks without ever getting out of this wheelchair. Thus, he ended up having bad sacral ulcers, which got infected and led to hospitalizations. So what you see here, this is not the patient, this is Bill, someone that we used to work with. And Bill has 2 mason jars in his hands. And in his right hand, the mason jar has 345 Scrabble tiles. And the left hand has like 4 Scrabble tiles. And these 2 hands represent the year before we knew Jack, and then the first year that we worked with Jack, and the number of days he spent at Maine Medical Center. And so how, you asked, did we do this? Well, we brought the greatest and best minds at Maine Medical Center together, and we thought long and hard, and we came up with a brilliant intervention. A $10 bed. Actually, I think it was donated free. And so this patient came in every day. He offloaded his wounds. He got on the bed. He had a place to store his cath supplies. He had a bathroom to have a place that he could, with some privacy and sanitation and dignity, do his self-cathing. And suddenly, hospital admissions for urinary tract infections and cellulitis dropped significantly. Over time, we also began doing a lot of wound care with him, which was something at the time we weren't doing. We do a lot of now. We started treating him for Hep C, which was something that we hadn't done prior. And he was also one of the first patients that we started prescribing Suboxone for. So the lesson about Jack here is that if you are caring for someone unconditionally and selflessly, you expand your scope of practice driven by the needs of the patient. And so I presented to you today these pillars of street medicine, and I present them to you not because I want the 40 of you to become street medicine doctors. Rather, I think that these are lessons that we all can learn from, and that there are pieces of wisdom here that can make us all better physicians, regardless of specialty. Now, back to the things that you guys have already done. It's abundantly clear to me that you guys have some of this knowledge and this passion already coming in based on the work that you've done. But I also want to say that medical training is hard, okay? The next 4 to 13 years of your life are going to be challenging. And so the real challenge is holding on to these values. But the good news that I want to share with you is that Tufts and the Maine track are the perfect place to help you do that. And I'll share a couple quick experiences of my own that helped me. The first is the Community Service Learning Program, CSL, and I do hesitate a little bit to share this photo with you because this was of Sherwood, our student-run clinic, which has changed drastically, and we'll leave it at that. But at the time, we entered this cold and empty gym every Tuesday night, and we would set up these walls of the clinic, and we would sign people up for insurance, and we would do sexual health screenings and school physicals, because those were big needs in that community at the time. And back here in the kitchen, when there was a lull, the older students taught the younger students physical exam skills. It was really such a special thing. And it was here where I started to learn skills about leadership and what it meant to work in the trenches with a team and collaborating and meeting community needs. Those are skills nowadays that really have played a lot in my development. I also want to say that just the fact that Tufts has a requirement sets it apart from a lot of medical schools in this country. And not only is there a requirement, but there's also a great program. I know Jen was here somewhere. And so Jen's the director of the program, and the curriculum and the reflective sessions that go alongside these service requirements are extremely impactful. The other thing that I want to mention is the Sam W. Ho Health Justice Scholars Program, aka HJSP. When I was a student, everything about health equity was taught in a one-month block, which was phenomenal and very much ahead of the curve in 2014. Or 2012, we would have done that. And over the years, though, this curriculum has now evolved into a longitudinal curriculum that all students get, and is really, really beautiful curriculum. But we also have this extracurricular track that students that are really motivated to do this type of work can receive extra mentorship and do some extra didactic sessions and we help them get some special clinical sites so that they really get to work with underserved populations. So just another way that Tufts is really helping to develop people's interests. So I'll bring you back to my vehicle. And by now, maybe the observant ones of you picked up on my rather nerdy license plate. And I appreciate that this is not for everybody, and I don't want you to all go get new vanity plates. But what I will say is that I drove this car during the years leading up to medical school and early residency, and it served as such an important daily reminder to me of the mission that I was on, that I was here to care for underserved populations. And so on those nights when I had bombed a test and the first time that I gave a tough diagnosis of cancer with a bad prognosis, or the day as a family medicine resident where you run from CPR on a patient that passes away to L&D to deliver a baby, but you walk out to this subtle reminder of why you're here and what you're doing. And so my message to you today in terms of this is just to think really long and hard to figure out what that daily reminder is going to be for you. I don't think that there's a right way, but having a way is crucially important. So in closing, I want to welcome you guys to the main track. In the olden days at a lecture like this, they would say, look to your left and look to your right. One of you won't be here at graduation. However, today I'm going to give you the main track version of that because it's very different. The main track is a small and close-knit community. It's a community that is dedicated to high quality patient care, to learning, to supporting students and providing excellent mentorship to the students in this program, and developing programs that cultivate people's passions. And a community also that loves one another unconditionally and selflessly. I will also share this very special photo of our first baby immediately after she's born because it really personifies all of those values for me. This photo actually is taken by an OBGYN resident who delivered our baby. And sure enough, a main track graduate. And now I could tell you so many stories actually about main track graduates that took care of my dad after his cabbage or my mom during her battle with breast cancer. So I'll say to you today, the main track version, look to your left, that person may deliver your baby someday. And look to your right, and that person may help care for your parent when they're in a time of need. And I'll leave you with one final closing thought here, and maybe it is advice but probably really a hope, and that's the hope that you make the most of your next 4 years. And what I really hope for you is that you fall in love with medicine, you stay in love with medicine, and let it decide everything. Good luck and welcome to the main track. Thank you, everyone. I don't know, Brendan, where we're at with, we're going to do questions for a moment, or I'm not sure what the final time decision was. Okay. Yeah, we can take a moment for questions. And while we're thinking about that, I'll just remind people again, I'd love for you to come check out the van during the reception outside afterwards. Well, I guess we covered everything. All right, thank you. Thank you.
Give me a minute to kind of get tears out of my eyes. That was really, really beautiful. Thank you so much. I am not confident of many things, but I am quite confident that the admissions committee did not make a mistake in admitting you. And as the current co-chair, I am positive that we did not make a mistake in admitting any of the folks that are sitting in front of me. So I'm Dina Weitzel. I'm the assistant dean for the Maine track, and I have the privilege of introducing the class of 2030 to you all. So if folks want to step up, we can get ready and hand out some stethoscopes. All right. So first up, we have Eliana Bonbreast. Wayne Brookshire. Catherine Callahan. Jenna Kluke. Daniel Cortine. Marguerite Dallaire. Tyson DeWard. Alexandra Dowling. Emily Downer. Lillian Vanberg. Gabriella Giftos. Harper Gordon. Tara Haas. Jonathan Harnett. Allison Harris. Grace Hodgkin. Emily Jones. Mahitha Jutu. Michaela Kendall. Liam Cohane. Elliot Comsel. Courtney Larson. Jasper Makowski. Elizabeth McGarvey. Julia Miller. Michael Mosley. Will Mullen. Dominic Needham. Claire Nguyen. Brooks Osborne. Daisy Parker. Angela Ploysangnam. Devin Quinn. Ivy Rika. Avra Ross. Elijah Rubianis. Dana Schwartz. Samuel Spector. Duncan Steele Maley. Shufen Sun. Tegan Tanner. Lucy Wellens. Thank you all so much. I think, yeah. We doing a photo? We'll give folks a minute.
Thank you all. So class, one lesson I'll share is humility. I forgot to do some thank yous when I started. So I want to say special thanks to Dr. Sawyer, Dr. Shodrin, Dr. Weitzel, Dr. Who am I forgetting? Yeah, where's Jen Heyman? Dr. Heyman, and all of your team here at Maine who are doing the heavy lift in your teaching. We're so grateful for your partnership. And to all the supporters who make the scholarships that we celebrate possible. Your impact on today and the future of healthcare in Maine is incredible, and we are so grateful. So I just want to say that, and a big round of applause. And I just want to thank Dr. Normandin for your amazing talk. And as a Jesuit-educated person myself, I just want to share that one of the tenets of Jesuit education is being a person with and for others, which is something that we do as physicians. But what you just walked us through, Dr. Normandin, is a master class in being a person with and for others. So thank you. Thank you for what you do, and thank you for being here.
Thank you, Dr. Boucher. Thank you, everyone and who presented. Thank you, Dr. Normandin. What an amazing talk. I'm Linda Shodrin. I'm the Vice President and Chair for the Department of Medical Education, which is where the Maine track lives. And we are so happy to have all of you. Usually I get to shake your hand, but today I opted out of the awkwardness. So congratulations and welcome. And I'm going to ask all of you to stay right where you are. We're going to do pictures. And I'm going to ask everyone else to please enjoy the reception that we have and join us for the van, and to just celebrate this amazing step in all of your lives. So congratulations to all of you. Congratulations to your family and friends. And hello and thank you to everyone who is online. So please join us out there for some food and refreshments. Congratulations.
Oh, okay.